Welcome to EM Rapid 2024. Today, we are going to discuss the topic heat emergencies. In this module, we are going to discuss the pathophysiology, the specific type of heat illness, the clinical features, diagnosis and management. Heat emergencies represent a spectrum of diseases that ranges from heat cramps to heat stress, and when severe cases that culminate in heat stroke. The body temperature is regulated by the hypothalamus. As the core body temperature rises, there will be sympathetic activation that in turn leads to sweating and vasodilatation. The various body heat dissipation mechanisms are radiation, convection and evaporation. The normal body temperature is maintained between 36 to 38 degrees Celsius. Even the temperature rises to 40 to 42 degrees Celsius, it is possible to maintain the body temperature for shorter periods. The physiological response to heat stress are dilatation of the blood vessel, increased sweat production, decreased heat production and behavioral heat control. Coming to the types of heat illness. It ranges from heat edema, prickly heat, heat cramps, heat stress and finally culminate in heat stroke. First we discuss heat edema. Heat edema is a self-limiting condition in poorly acclimatized individuals. It is manifest as mild swelling over the feet, ankles and hands. Coming to the pathophysiology of heat edema, it occurs due to the cutaneous vasodilatation and orthostatic pooling of the interstitial fluids. Ankle edema may or may not present in some cases, and treatment is mainly supportive in nature, that is elevation of the legs. Next we come to heat cramps. Heat cramps refers to a painful, involuntary and spasmodic contraction of the skeletal muscles. It occurs in individuals who are sweating profusely and replaces fluid loss with water or other hypotonic solutions. It occurs during exercise and during resting periods after strenuous physical activity. Coming to the pathogenesis, it occurs due to a relative sodium, potassium, magnesium channel deficiencies. There can be fluid deficiency at the muscle level. Rhabdomyolysis is rare but can be seen in severe conditions. Coming to the treatment of heat cramps, it is mainly IV fluids and rest. It mainly aims at rehydration. So, the mainstay of treatment in heat cramps are fluid and salt replacement, rest in cool environment and rehydration with IV fluids. Now we come to heat stress. Heat stress is a part of the continuum of heat illness, but that does not meet the criteria of heat stroke. Heat stress results from water or sodium depletion or a combination of both. Coming to the symptoms and signs, there can be headache, nausea, vomiting, malaise and muscle cramps. There can be dehydration, tachycardia, orthostatic hypotension and syncope. One thing we need to notice is a normal or slightly elevated temperature that can be seen in heat stress, and there is no CNS impairment in heat stress. Coming to the lab investigations, we can see electrolyte abnormalities, hyponatremia, hypovolemia and hemoconcentration. Coming to the treatment of heat stress, it's again mainly IV fluids. Volume and electrolyte replacement and rest are the mainstay of the treatment. If the patient is having significant hypoperfusion or hypotension, you can administer fluid boluses. Hospital admission is seldom required, except in patients with congestive heart failure, in patients with severe dyselectrolytemia, and severe heat stress can lead to heat stroke. patients who are not responding to rehydration in 30 minutes, the cooling techniques are advisable. Now we come to heat stroke. The cardinal features of heat stroke are hypothermia and altered mental status. Sweating may or may not be present. Cerebellum is the most vulnerable to heat stroke. There can be ataxia, other CNS symptoms like seizures, altered mental status, loss of consciousness can be seen. Neurological injury is a function that is mainly affected by heat stroke. Coming to the differences between heat cramps, heat stress and heat stroke. In heat cramps, there can be muscle cramps. Heat stress contains the symptoms of heat cramps, and in heat stroke, the similar symptoms of heat stress can be seen. The body temperature is normal to mildly elevated in heat cramps, and also in heat stress also there can be an elevated body temperature. Sweating is present in heat cramps. Orthostatic hypotension, nausea, vomiting, headache are present in heat stress. The cardinal features of heat stroke is the neurological abnormalities. Coming to the differential diagnosis of heat stroke. Infections like sepsis syndromes, meningitis, encephalitis, endocrine disorders like thyroid storm, pheochromocytoma, neurological disorders, toxicological disorders and alcohol can all mimic heat stroke. Coming to the lab investigation, the lab investigation is directed towards detecting the end organ injuries. You can try the CBC, ABG, metabolic panel, coagulation panel, CPK, myoglobin, X-ray, chest radiograph according to the organ involved. Coming to the pre-hospital care, when we first see a heat emergency, especially the heat stroke, you need to remove the patient from the hot environment, and we need to perform standardized resuscitation measures. Check GRBS if altered mentation is present. Remove the clothing and start cooling in the patient. And we need to start the patient on IV fluids if hypotension is present. The goal of therapy in the emergency setting is to start immediate cooling and aggressive support of the organ system function. We need to continue the standard resuscitation measures and administration of IV fluids depending upon the cardiac output, the urine output, the dehydration status of the patient. We have to monitor glucose levels if there is altered mental status. And finally, we need to monitor the core body temperature. Coming to the cooling techniques, it is the only physical methods of cooling which are recommended. No evidence has been there to support one cooling method is prior to another. Primary physical cooling procedures are recommended as the mainstay of treatment because it is the one that allows easy patient access and one that is readily available and easily tolerated by the patient and the most effective one. The goal of cooling technique is to reduce the core temperature and to avoid overshoot hypothermia. If initial cooling method used does not lower the temperature quickly, you can try other methods of cooling. Coming to the various cooling methods, first is evaporative cooling. It is the most practical and comfortable for the patient, in which we will remove the clothing, we will spray cool water on most of the patient's body surface and we will direct a fan over the patient that facilitate evaporation. To prevent hypothermia overshoot, some recommend using either tepid warm water and exposing the patient to hot air. If the skin temperature is reduced to less than 30 degrees Celsius, shivering will result in more heat production and there will be peripheral vasoconstriction which will impair evaporation. The problems with evaporative cooling is one is shivering, which can be treated by short-acting benzodiazepines and phenothiazines. Then we come to immersion cooling. Immersion cooling is performed by placing the undressed patient into a tub of ice water deep enough such that it covers most of the patient's extremities, the body, keeping the head of the patient out of the water. The problems are there can be shivering, there can be displacement of the ECG leads and inability to perform defibrillation or resuscitation. The safety profile in elderly and cardiovascular risk patient is not yet established. The alternatives can be massage with ice water, but it is not effective as a single modality of cooling. Coming to other invasive cooling measures. This is used when immersion or evaporation cooling methods are not effective or not sufficient. Coming to the various methods of invasive cooling, one is the cardiopulmonary bypass, which is the most rapid method, but due to the logistic unavailability, which is a major disadvantage. The other invasive cooling measures are cold water gastric lavage, cold water urinary bladder lavage, cold water rectal lavage. The disadvantage is that patient cooperation is needed and the chance of water toxicity is more. The efficacy of these methods are questionable. The other cooling methods include cooling blankets, IV cold saline infusion, applying ice packs. Antipyretics are of no effective, dantrolene is not recommended. Coming to the complications of heat injuries, there can be the most important complication: hypotension, dyselectrolytemia, hematological abnormalities, coagulation abnormalities, organ dysfunction, liver injury, respiratory failure, renal failure and cardiovascular failure. So, in this module, we have discussed heat emergencies, the different spectrum of heat emergencies, the clinical features, the diagnosis, the management, including the various cooling techniques. Thank you.